Hi friends, it's Jess with Our Bipolar. Welcome back to my channel. Today we have Moss back on the channel. She's my dear friend and I'm so happy to have her here. We're going to talk a little bit about hospitalization for bipolar and also home care, if that's the way you go instead. But first, I'm going to ask you to please subscribe to my channel and like this video if you like it. Thanks. And comment. We love all the comments and we'll definitely be answering them for you. And we're going to do something a little bit different to start. I'm going to ask Moss to tell us about her bipolar diagnosis.
My official diagnosis is the bipolar 4. No, I'm just kidding. They're not. There's no bipolar 4, but it's bipolar, not otherwise specified. And then mine has the tag with psychosis. I was given that diagnosis based on a couple of primary criteria, and that was experiencing psychosis outside of mood episodes. And I also have a lot of rapid cycling and mixed cycling. So I get into the other category.
As some of you know, I have bipolar type 1, and that is if you have the full-blown mania with depression. And I also have had psychosis, but not for many years. And then I just wanted to ask, how are you doing today? Like, what's going on with your bipolar and just if you're feeling any symptoms or not?
Well, officially in the records, it says the most recent episode, hypomanic. I think that was very kind of my psychiatrist. I think I had mania symptoms completely for the about 3 weeks after the evil clock change.
Mm.
Um, so that would be my most recent episode. Otherwise, I would say that I have been euthymic the past month with situationally appropriate moods. There's been a lot of stress in the household.
Right. I know. And like you, I've had a lot of stress in our household too in April, if you guys saw my Get Ready With Me video. But somehow I'm staying stable, but I am inching toward hypomania. I have taken some extra Seroquel, but not for the last couple days. So I'm like holding steady, but there's still a chance. I'm ramping up my YouTube channel and filming more just like today. And, the anticipation of that can lead to hypomania, at least for me. So, okay, well, let's launch right into our topic. First, let's see. We were going to talk about, why is acute treatment needed and why do you need more intensive care rather than a regular daily treatment?
Right? I mean, probably in early stages, or for me, for many years, I wasn't very good at noticing any mood slides, and I would have the rapid cycling, so it would come on suddenly. But as I've learned to become more aware of earlier signs and symptoms, my most recent hospitalization, November 2 years ago, I just was I was having a lot of rapid cycling, which for me is the most distressful, mixed with mania, not really much depression. And I could not manage it with all the at-home care that I knew. I couldn't manage it with the help of friends and family. And I was hesitant to go, but I talked about it with people close to me, and we all agreed that it was the right choice to go. I went primarily to see about having medications changed. And I live rather far from my psychiatrist. So to go back and forth or to have the medications come back and forth was a window of time I wasn't willing to risk with my mental health. And so I would have gone to outpatient therapy perhaps if that had been available locally, but going as an inpatient gave me a safe place to try different medications quickly and get the rapid cycling under control.
Yeah, that makes a lot of sense. Did you go had you been speaking with your psychiatrist before you went? And did your psychiatrist agree that you should go inpatient?
I'd actually not been in good communication with my psychiatrist, but I did contact my psychiatrist when I began to actually I waited till after I spoke to my family. Um,
Mhm.
my luck, the psychiatrist was on vacation, so I got to meet and speak with the psychiatric nurse who was fantastic, did a great job filling in. And the psychiatric nurse walked me through the steps of what I would do, where I would go, what kinds of things I needed to take with me, etc. And did, message my provider in on everything and get the okay. But it's kind of considered like going to the ER for a broken bone. If you need inpatient hospitalization, at least under my healthcare program, you don't need like a pre-authorization. You don't need your doctor's permission. You can just show up at the ER and admit yourself or ask,
Right.
for care. But we did plan and I did call the hospital in advance so that they knew that I was coming and have records forwarded and ready, all that.
Okay. Well, that's great. But like you said, you don't have to do all that. You could just go to the ER and just go from there. Just so you all know, I actually haven't gone inpatient and I haven't done an outpatient program either. There are at least 3 or 4 instances or times since I've been diagnosed that I probably should have and did not. There was a lack of knowledge on my part. There was a lack of action on the part of my doctors. And I do think that I was failed in some ways because of that.
That's unfortunate to hear, but
Yeah.
maybe missing those hospitalizations has given you more knowledge about managing at home. What do you look for a switch from like, okay, here's my daily lifestyle and medications and everything I do to wait, I need to be doing more. I need to what do you use as that criteria? Or like was there a recent time where you really had to kind of have more acute care at home?
Yes. I mean, it usually happens at least once a year that I have to kind of buckle down and, take more medication, notify my psychiatrist. It can happen more than once a year. But what I do is typically I'm, starting to go towards hypomania or mania. Once I get into hypomania, I have kind of a plan in place that I will up my Seroquel. This is what my psychiatrist tells me to do as well. I contact my psychiatrist and let him know what's going on. And I make sure that my husband Brian knows just so he can keep a closer eye on me because I think, like a lot of us, I really am good at masking it. If I didn't say something, I could probably go on for like a week or two and he may not notice. I mean, he might, but he might not. And then the other things I do, like I really am careful, much more careful about sleep. And the extra Seroquel helps me to sleep more. And I stop all sugar and caffeine. I already don't take in a lot of sugar and caffeine, but I really like take it down to zero. And I just usually need more alone time. I need just to be able to stop as much stimuli as possible or any outside stress. So I might stop attending any kind of social event or activities. I will just cancel plans with friends or family. I mean, I just really like buckle down, like hunker down, and
Mhm.
that's what I'll do. And if it wasn't working, like I will have to check in with my psychiatrist in those cases like every few days, and if it wasn't working and I was still going towards mania, I do think that would be when I probably would talk about doing something else, being
Right.
hospitalized, possibly.
So it's all those steps that you take, like the most likely thing that you see as a sign that you need to take those steps is hypomania sliding into mania. Because like for myself, it's the rapid cycling. For someone else, it might be depression. It might be thinking that, they don't want to get up the next day. For, each person with bipolar, they'd have to know what is like their warning signs. And for you, it's that the hypomania, you've got to get on top of it like right away.
Right away, yes. And when I was younger, when I was on different meds that really weren't working for me, I think then it was, the thoughts of not wanting to go on and those getting really strong and like becoming a plan. Those times, this was much earlier on, so this was probably like over 20 years ago. I really should have had more care. I should have been admitted to the hospital in those cases.
Well, thankfully, you made it through them.
I did.
Anyway, it's not necessarily the kind of wisdom that you might want to acquire, but now you have it. To get through
Yes.
such things. I mean, it's possible. Um, since beginning lithium therapy, the most catastrophic of self-sabotaging symptoms have really been like nipped for me. I do also have it as a symptom of migraine sometimes, which is like really weird. I have to just remind myself, I'm like, it's just the migraine. It's just the migraine symptom. Wanted to try to see here if I had some of my little questions ready for you.
Yeah.
I think we talked about like some of the alternatives that we might consider. Like I might, if I could have gone to outpatient care, since I really just wanted to go to the medication adjustments, like I would have done that. But as I am aware, I think like outpatient care is more of like the therapy oriented, the classes and the groups and things like that.
Hmm.
Which in the in-hospital setting, at hospital policies vary by each hospital, but the one that I was at, you did not have to go to groups and therapies, and that was great. I just stayed in my room and slept, which is what I do mostly for acute at-home care.
Yeah, that's what I do. I'm glad to hear that. I had no idea. I thought that when you were in the hospital, you had to attend those group sessions.
It varies by hospital. There are
Okay.
hospitals that insist. There's also ones that have, exercise programs. I think we're going to talk about that a little bit about like the procedures. Is that our next thing? Oh,
Oh,
it's who's going to be involved in our care. I was really curious to hear your answer on this because I have a very small family unit. For me, at home acute care is basically one or two people in person and then a remote network of long-term friends or short-term friends that have become kin. And everybody checking in, making sure that I'm on top of things. But it's a very small group. I don't like to usually check in with my psychiatrist frequently or anything. And then the hospital setting, that's very regimented. You might not have to go to like groups and classes, but you are going to see the psychiatrist probably you're good every day, if not more than once a day. If it's a teaching hospital, you might have students coming through also. You're going to have nurses taking your vitals because your vitals have to be in certain parameters for the medications. So you're going to see the pharmacist. You maybe will see a regular MD if you need to see an MD. If you have things just like a backache, a cold, flu, you're just going to see the nurses that are on the ward. Again,
mhm.
in my hospital experience, which was at a public hospital, a federal hospital. There's access to clergy, but you don't like have to go.
Mhm.
You can ask for them to come and see you. Visitations are always going to be restricted, whereas like with that home care, maybe that was something you would self apply, like just decide as a rule, I'm not going to have anybody over for the week. Whereas
Mhm.
like in the hospital, all of those things are set upon you. And there is kind of you don't have to socialize, but it is being marked in your records the whole time you're
Oh,
there.
really?
Of
Okay.
yeah, of how well you're socializing. I mean, especially there are patients that might be combative, and so that
Mhm.
has to be addressed. Um, or if someone is there for deep depression and they're just completely withdrawing, but
Yeah.
your social behavior is recorded, very like kindergarten class. So I was wondering, that team of people is set by the hospital.
Hmm.
What for you is like the team of people? Do you have clergy that you check in with?
No, I am not religious. I don't have any contact with clergy. My psychiatrist, I'm instructed to contact him when I'm symptomatic in any way. And for me, it's usually hypomania first. So what I do is I simply email him and, we converse over email outside of appointments. At this point, he knows that I know what to do. I always increase the Seroquel like a certain amount. It's usually the same every time. Sometimes it'll be slightly more, but I already take a very small dose. So I contact him, I increase my Seroquel. I may increase the Seroquel before I even contact him, just because I know I need to do it. I tell Brian, my husband, and I usually talk to maybe a small handful of other friends, and it's more just for support, not because they should
Right.
keep an eye on me. My really close friend Keith, who used to be my neighbor in DC, I talk to him all the time. I
Shout
talk to
out to Keith.
you. I talk to you all the time. There's a few other people who I might kind of clue in, mostly because I may or may not be as talkative, or I might be more talkative. I might be acting slightly differently, and I want people to know what's going on. And that's really it. I don't talk to family about it unless somehow there's a reason. Like, let's say there's a holiday coming up and I need to bow out of it.
Right.
Then I might tell my parents or, my brother. But
But
that's
you're more informing them than really requesting any support. What
exactly.
about what about with NAMI? Do you attend any of their like groups or peer support things?
No, I don't. I don't
Would
attend.
that be worse for you during an acute period? Because the reason I say that is like that forced socialization in the hospital was worse. I had to take anxiety medicine for that I wouldn't have needed if I had been at home.
Yeah, I'm exactly the same way. That would be worse for me in that at that time. It would definitely be harder for me to do. I actually was in talks of becoming like a peer support trainer with NAMI, but that's not really the same thing. I'd be leading a group. This year has been so stressful. I just knew I shouldn't take that on. Yeah,
That's important in an everyday care or the acute care, knowing what you can really take on that day. And I think you,
definitely.
you said it's great you can communicate with your psychiatrist by email. I have like secure messaging, but they might be on vacation. Um,
Yeah.
and you said that you talked every 3 days. Is that just during the acute phase, or is that how frequently you normally check in?
No, that's just during the acute
Oh, okay.
phase. I usually see my psychiatrist like once every month, sometimes once every 2 months if I'm doing really well. My psychiatrist doesn't take insurance. It's super expensive. So I try to go as infrequently as possible.
Yeah.
But I do communicate with him outside of those appointments. And it's not always every 3 days. It's just,
Right,
when needed.
right. So both of us have a pretty small pod for at-home care at the
Mhm.
hospital. I've got a huge team, which there's pluses and minuses to that. It's very efficient. If you have 8 people and 40, 50 patients,
Mhm.
um, that's techs, phlebotomists, like everybody. One doctor, maybe 2 doctors.
Okay.
Um, and that to me was actually an overwhelming amount of people. Maybe for some others with bipolar, that would be great to have all that like extra support. I do now speak with a social worker occasionally during acute phases. I didn't realize the scope of what social workers do until my last hospitalization, and a social worker was one of the people we had to meet with. And I was like, oh, you do more than just take kids out of people's houses. That's kind of the only thing I knew about social workers.
Yeah.
So that is one other additional person I have on my team. What I'm thinking of, like, my younger years when I really didn't have support. If we were just to give our peer advice, what would you say for people to do if they don't have any kind of pod or support? They don't have any insurance at all. They can't afford a private provider.
So
And
you're
there's,
saying they're not seeing a psychiatrist at all?
or, or maybe they're going once a year, once every 6 months, for medication refill, and that's it.
Well, you might know better than me, but I was thinking in those cases when it became, severe symptoms, severe depression, severe mania, psychosis, I would say to go to the hospital. I'm not sure what
Oh,
else you
it's
could do.
no, I would say if it's safety, if it's your own or other people's safety, and that includes your psychological safety. Your psychological safety is equally as valid, excuse me, valid
Hmm.
as your physical safety. And if not, literally just, it's really hard to do, especially depressive phases. But it can be hard in manic phases because like nothing's wrong, everything's going great, even if it's going horribly dysphoric. But gosh, just reach out to every single person you know. You maybe the same way that, like, when we address a big topic with children, we do it in an age appropriate way. So you reach out to each person in a relationship appropriate way. Whatever level of relationship you have with that person, kind of
Hmm.
give your little hint. When they say, like, how are you doing? Go, actually, I'm struggling a little today. You never know who will reach out and help. I've had some stellar people step up for me.
No, that's great advice. I was thinking more like this is an emergency
Oh,
situation.
yes.
Like you are a danger to yourself, a danger to someone else, and that's sort of what I mean by severe mania, psychosis, depression. But I get what you're saying, and I think that's really good advice.
I do agree with you, and I'm going to stick to the voluntary hospitalization for the talk. But when I was on a psychiatric hold, I knew it was an emergency situation. I still did not call the hospital. I actually called my boss. But, you know, boss knew what to do, and boss got me to the hospital. So,
No, that's great because sometimes people don't know what to do. Like I was telling you, I had a boyfriend who he just I didn't know what to do either. It's not like he just didn't know what to do and he should have. Not at all. But, when I'm talking to him about ending things and having a plan, he really didn't do anything to help me and didn't say you should go to the hospital. And, sometimes people don't really know what to do.
yeah, yeah. So, Jack, the hospital does know what to do. So, go ahead and go there. And you might have a very large bill, but you also can die without paying it. So it's all right.
Oh gosh.
Well, I mean, you
Well,
can't let the okay, if you are thinking, I don't want to live another day, but you're also thinking, I don't want a hospital bill, then you are actually wanting to live another day because you're thinking about a future in which there's a hospital bill.
that's a very good point.
So get yourself some help. Go to the hospital. You'll be okay.
I agree. I agree.
I think we'll speak next about some of the specific practices, and you talked about some of your adjusting your medications, turning down events. Like, what else is you changing your diet? So you don't keep that diet? You don't keep the acute diet all the time?
No, well, I keep it to an extent, but it's not. the truly Spartan, no sugar at all, no caffeine at all. I mean, I might drink decaf coffee once in a while. It has a little caffeine in it. But once I'm starting to feel symptoms, like that is done. Sugar doesn't affect me as much. It really hasn't seemed like it will push me toward hypomania or mania. But if I'm in hypomania, it can make things worse. It
Yeah.
could exacerbate and push towards mania. So I do stop the sugar then.
I've got some strange genetics. Sugar makes me sad. Sugar makes me depressed. It also makes migraine worse.
Well, that's another reason I try to
Yeah.
keep a small amount of sugar in my diet, but not a lot. Yeah.
So I was wondering, I know we've talked about this privately before about, and actually, I mean, pretty much everybody in the bipolar community talks about the importance of routine. Your psychiatrist will tell you all about the importance of routine. You know, in the hospital setting, it's they're managing multiple patients. So what's going to be best practices there might be helpful, might be harmful, but the same way also, I think maybe best practices at home, maybe you're not advancing your own wellness as quickly as you could because there's not the like rules and regulations in place. I know like in the hospital setting, the clock rules the day for sure. Everything is done exactly by the clock. There's no dragging your feet. If you don't feel like going to breakfast, you're going or you're not eating. That's what's happening. You know, there's going to be very strict safety measures in place. You know, nobody's going to have, not only are you not going to have like a pocket knife or anything that would be traditionally thought of as a weapon, you are not going to have laces. You're not going to have the string to your hoodie. You might not have the hood. They may make you cut the hood off.
Oh,
You know, you're visiting, like you say, you choose not to take on extra social events. Well, you know, inpatient, that is enforced. You're not going to have just people coming by whenever, hey, how you doing?
mhm.
Your visitations are limited. Stimulation control can really vary at hospital settings. I'm guessing that that's something you've got a lot more control over in the home setting. But
Sort of. Well,
we couldn't open and close our own blinds. We had to ask somebody, please
oh,
come.
wow.
Well, because blinds have cords, and so they had a little key that would turn it, and you know.
Okay. Yeah,
Um,
that makes sense.
but you know, in one hospitalization, the first hospitalization I had, exercise was part of the program, which all you had to do was just walk in a circle, you know, it counted. But there's going to be strict rules about grooming and grooming supplies, writing supplies, everything. Having done both the hospital and at home, I know what I was doing before that I always called like self hospitalization.
Oh, okay.
And then I got to the hospital, I was like, oh, they do these things here too. And there are things that, you know, I took away from there and I was like, oh, I can do these when I do at home
Mhm.
care. So for you, are those things you change at all? These are things that I think are like specific to the hospital environment. And I'm wondering if you incorporate them. And that is the types of clothing. Like, do you let yourself be in loungy wear or does that make you feel too depressed and you like make yourself get nice every day?
Well, I do
Like,
loungewear wear like every day, all the time. So that's not, that doesn't change.
okay.
What does change for me? So, I have a husband and a daughter, and there's a lot of stimulation. So if I'm having hypomania, I need to somehow remove myself from just being around both of them. And, I want to be around them, but I just can't when I'm in hypomania or mania. So what I will do is sometimes I will like go down to the basement and I will maybe spend most of the day there or whatever I can do. If that's not enough, I will go somewhere else. So I will sometimes go to a park if, the weather is good for it. I will sometimes go to my parents' house and they know that they have to leave me alone, and I will be in an upstairs room with the door closed. I will also try to cut down on watching TV, being on social media. those things are harder for me, especially social media, because, we have a lot of friends on social media, but at the same time, I need less interaction.
But that is something that is done at the hospital. It's
And
taken
it
away.
is.
And
Exactly.
when you're at home, it's hard to do, but it is actually therapeutic.
Right. And I'm also just trying to stay on my normal routine, which is, getting up around a certain time each day, getting enough sleep. Usually I need like 8.5 to 9 hours. So I'm making sure I do that, even if it's aided by medication. I'm, eating at the same times I always do, eating really healthy, of course, because I'm trying to not have sugar.
So I have a
Yeah,
question
just
for
sort
you.
of go ahead.
In all the things that you take away, what do you fill that time with? Do you exercise more? Do you read more? Do you just sleep more? Because
That's a
there's still
good
going to be the same
question.
hours in the day.
That's a good question. I usually still work, which is probably not the best thing to do, but I'm always concerned with that obligation. Now, if I'm not doing so well, I will take time off work. I've taken, 2, 3 days at a time before, and I have a lot of vacation time at work. So I'll just take it. And my job, I don't have a lot of deadlines, so I can really just take time off. But I do usually try to work above all else, which is not the right thing to do.
Well,
But
you've
I'm just
taken
being
like
honest. I'm being honest. This is what I do usually.
Well, I mean, if okay, let's just in our, we have a plate in each hand, and we're like, both these plates are heavy. I've now entered an acute phase. I can't hold both these plates anymore. And if you're putting down everything from one plate, well, maybe it's okay. You can still do the job stuff. Like that's enough taken away that you could still do that. It's okay.
Sometimes, yeah, and sometimes that's true. And maybe at work, I'm a little slower or I'm not able to concentrate as well. That happens for sure. But I do my best and I definitely, I'm cutting out a lot of things. Yeah.
Yeah.
Is that what you do when you're like doing your home care as opposed to when you were inpatient?
Yes. And I've been medically retired since 2006, 2008. So a while. I haven't had the pressure of work. And so before hospitalizations and after caring about doing something about bipolar, not counting all the years where I didn't care and I just have, episodes, whatever. Um, I would, because rapid cycling and mania is the more primary concern for me, I would just sequester myself. I would just change, not even reading and writing, like any stimulation is too much. No meditation, music, like if it's very bad. And so, when I went to hospital and I was like, oh, that's what they do at hospital too. Okay. So I'll just do that when I get back home again. The most recent time I was hospitalized, I was too far away really to have any visitors. The first time I specifically signed when it was like, who do you want to allow and not allow? And I was like, nobody. I don't want to see anybody.
Mm.
So I do the same thing at home. I'm very introverted anyway. But I just know I don't either. I want to avoid lashing out at them. Like I want to avoid being symptomatic in a personal way.
Hmm.
And I also want to get out of the episode, which usually requires cutting off stimulation and getting sleep. I do actually. I am not a loungewear everyday person. I'm wearing jeans and a t-shirt. This is casual, and I will like go to like hospital mode now with the clothes. I'm like just I'm the type of person that like I don't wear my bed clothes to like go eat in or to go check the mail. I change the clothes,
No, I
but
think that's healthy. But what I do is the opposite. I found pants that I can wear like to bed, to work. I could wear them
I
out
will if
even.
I have to. I will. I will. But when I'm in acute phase now at home, like I remember that from the hospital. I was like, oh, I can go to a meal in my pajamas. I can, do my video call with my psychiatrist in my pajamas. For me, that's something that I do actually change and shift. And just like putting away the social media, putting away the clothing pressure is actually therapeutic also. It doesn't necessarily seem like much, but it's like every bit of cognitive burden that we can let ourselves go from, then I guess our neurology can take that energy and heal us from the episodic state. I did want to make a point about, I think, about safety, like at home versus hospital.
Mm-hmm.
I would recommend anybody, if you think it matters in your life, whoever your pod is, to make sure that they keep a physically safe environment for you if you're not able to make it for yourself. Um, Not a problem in this household today, but honestly, historically, there have been times. And I'm very glad that there were people who kept me physically safe.
No, that's
So
a great point. And I wouldn't
don't
have
be
thought.
afraid to just like, don't be afraid to tell people I don't want to wake up tomorrow. Be brave and tell people like that's really tempting. I need you to remove it from my area.
That's wonderful advice. And I wouldn't have thought of it.
Well, it's good if you never have to think of it.
If you think of it, yeah,
But
that is
I mean,
best thing to do.
it's an unpredictable condition.
Hmm.
So to go ahead and think about like if this might be the worst case, I'm prepared for it, and then it never happens. While like the hospital is a lot stricter and you're going to have to see a lot of people, it really sounds to me like a lot of the best practices are the same, you know.
Well, that's good to hear for me because I do feel because I haven't gone inpatient and I do think, I should have. That is good to hear, but I think I also, my home care has transitioned over time. There was definitely a time, like I said, where earlier on I was not doing these things at home and I was going through really tough times and I was having those thoughts of like, there should not be a tomorrow. And I just had no coping skills and no real support. And so now it's completely opposite. And it's like I almost needed to find a provider to show me, like to say to me, if you're having symptoms, you need to contact me.
Mm.
Like that wouldn't have entered my head if he hadn't told me.
No, I think everybody that I personally know with bipolar has lamented that like here's diagnosis and no further information. Like just a little pamphlet like you do for heart disease that says, don't, avoid eggs, drink some orange juice. Just give me a little pamphlet that's like says like if you are feeling this kind of sad face, call us. If you are feeling this angry face, turn the lights off. I don't know, just some basic things. Some very basic like self-care, contact us thing. I don't
Yeah.
know. That would have been really helpful. So that goes back, we talked about like looking like what symptoms to look for that we need to either go to the hospital or go into acute home care. What are you personally looking for to say like, okay, actually I can go a little bit back to my baseline? How are you making those assessments? Like in the hospital, that's real questionnaires and check marks and assessments. Do you actually have like an Excel sheet for yourself?
Well, no, definitely not. I'm not that organized. But what I do, so if I'm going into hypomania, which is usually what's happening in my life, that's what I go toward. I've already been in communication with my psychiatrist. I've already increased my Seroquel, which if I haven't said, is an antipsychotic, and it also makes you very sleepy and sedated, which helps with sleep. So after, a little while, depends on what's going on, but after a little while of increasing the Seroquel and all these other changes I've made in my lifestyle, I usually things start to sort of quiet down in my mind some. I'm not having the racing thoughts, the agitation, feeling sort of elated, but also extremely irritable because I have that dysphoric hypomania where it's irrationally irritable, like just irritable about any possible thing, anything. And so when that starts to go away, and also whenever I just don't feel quite as revved up, I know that I'm sort of coming back down. And then what usually happens is my doctor wants me to stay on the Seroquel. But then as I'm coming down, the Seroquel starts to make me feel even more lethargic and tired because
Yeah.
I'm not really needing it anymore. And after a little bit, my doctor will say that I can just stop taking it. And then sometimes, sometimes I still need it again. Like I took it
Yeah.
away too soon.
Yeah. I think that's a good marker of like increased side effects because then you've changed that like threshold of efficacy or, blood concentration levels or whatever.
Hmm.
Um, I know like I have to have my lab works tested because lithium.
Hmm.
Um, and that was also part of why I wanted to be in the hospital setting because I wanted to try that for the first time. I was terrified of it because of its stigma. I have medication sensitivity, so I'm like, I'm going to be the 1% that reacts badly. No, I'm the 1% that reacts great to it. But with like at home care, I know that I don't do any labs or follow ups or anything like that to
No.
test. So you're kind of just going on the balance of the effects to the side effects. That's pretty
Hmm.
smart. I'm gonna incorporate that. Like the side effects are getting too strong. I do that a little with lithium. And like you, I've got some trust established with the psychiatrist of saying, like, I know when I need to go up or down on it.
Hmm.
And I'll have so many days in a row where I'm like, okay, too many side effects. We're going to have to go down on this. Not necessarily because the acute phase has passed or that I'm in a good mood state, but the side effects have just become intolerable. And then, like you said, we'll go back up. It's just the way it is. You got to go up and down sometimes with them. Either work very
Hmm.
closely with the psychiatrist or have that trust really built in. Just a little tangent. When you spoke about irrational rage, it reminded me, I knew one time that I'd really crossed over into mania when Bob Ross was just like infuriating to me. I couldn't, I was like, I can't watch this man paint. It was enraging. And I was like, this is the most peaceful human on TV.
But I so relate to that. Like I could have been in that place. Definitely.
It was like, Bob Ross. And I know, like, so checking, adjusting the medications, checking for the side effects, just generally like improve you feeling better, maybe
Hmm.
having like less brain fog, better cognition
Hmm.
coming back, energy levels. Just kind of watch, like you're kind of just watching your own biomarkers, not necessarily
Yeah.
like taking your vitals, like your blood pressure or anything.
No, no. But yeah, I mean, because a lot of times I have, more energy as I become hypomanic, but it's like a very agitated, nervous energy. And then when that starts to go away and I come back to like a normal energy level, I mean, all these things are usually happening at once. Things are calming in multiple ways.
Do you have like any one thing that for you is like, okay, I'm okay now? Because I think like in the hospital they ask you, what's your goal? What do you want to have in place that you would feel comfortable leaving here? And for me, it was the whirlwind of rapid cycling to just cease. I didn't care if I left manic or depressed. I just wanted to leave not in rapid cycling. Like that's my criteria. For other people, they might have a higher criteria stabilization, or it might be something like I want to be able to watch Bob Ross again.
Yeah.
Do you have anything that's like that like is a key marker for you?
For me, it's the irrational irritability. It doesn't even have to be rage, just the irritability over everything. Because I've had it where all of my other hypomanic symptoms have gone back to normal, like to like stable levels, but I still had that irrational irritability and it lasted for, I think it was like another month. And that was so frustrating. I just don't want to be going around my life and just feeling that that bad energy.
No, I mean, it doesn't emotionally, it doesn't feel good. We see the impact it has on those that we care about. And it's also physically bad for us. Like, there's, you all can go to Bing and Google and search. The research is out there. Every time you have a mood episode, all of those biochemicals going through the body have a physical effect, just like if you sprain your ankle or have the flu. You
Mhm.
know, it can, there's studies that show that it can lead to, long-term cognition problems. But I know, like you were talking about, just knowing your own body markers for how you're feeling. I can feel mania as like a physical sensation sometimes before I recognize it as an emotional state, because it's those neurochemicals like
Mhm.
heightening it up. Yeah, that's what you're saying, the rage. So you don't want to feel like that emotionally, and it's not good for the body. It's just not. You need to be, physical health and mental health are one thing.
Definitely. Definitely.
So for you, you to like, when if you're out of the irrational rage, that's when you would say, okay, I can end the acute treatment.
Yes.
Yeah.
Because
And but
that's usually the last thing to go away.
and will you like slowly incorporate back, or will you just be like, tomorrow's the day I'm going back on schedule? Because the hospital, it's one day. Sunday you're in the hospital routine, and Monday you are on your own reconnaissance.
No, I don't have a hard cutoff. I mean, I do what I think is best for my body and based on my symptoms. If I'm still symptomatic, I'm still treating those symptoms and I'm still treating with medication, lifestyle, like buckling things down. Yeah.
So it's got like, you've got a good transition stage phase.
I guess I never thought of it that way, but you're right. It's a very slow change back to normal, which is just sort of how my body is, I think, but that's how I act too.
I think that probably is the better way. There needs to be I personally think there needs to be a transition program for hospitalizations, whether it's voluntary or involuntary, like that little pamphlet.
Yeah,
There should
exactly.
be follow-up care. There should be somebody that calls or checks in. We're global audience here, and healthcare programs vary, but it can be the case, with public healthcare in America, that you leave the hospital and your first follow-up isn't for 3 or 6 months. That could be a long time that you're on the wrong medications or maybe symptomatic. And I think that's an area in which at-home care kind of excels,
That's
because you've got
true.
that
I mean,
transition.
don't some people do like an outpatient program after being inpatient,
That's a good, yeah, there are, you're right.
but not
There are,
always.
yeah, depends on the insurance
Hmm.
and the finances and the
Gosh.
ability. I mean, even, health services are, unfortunately, become a privilege rather than a right. And access to care can be a challenge for a lot of reasons.
Yeah,
And that's valid. That's why we want you to know that you can do at-home care too.
exactly. Yeah.
Both, having done both, they both had their benefits. I learned a lot. I feel like both times that I was hospitalized, I learned two very good lessons. The first one is, you need to keep your bipolar in check enough that society does not lock you away. The second time I learned, oh, this is actually a lot of stuff that I can do at home. And it is also available in a supportive environment, because I don't have the large personal support network. So the hospital is a place where I can have physical safety, not for like the dire reasons, but if you know medications, etc.
Mhm.
Um, and it is a place where you can drop all the plates. You can't bring any plates in with you, so
That, yeah, I
you
feel like
do get
that
to
is a huge
completely focus on
benefit.
yourself. Yeah. So they're that's my summary. Is they're equal but different. They're cousins, not sisters.
Yes. Well, I still think, a day may come where I need to be inpatient, and that's okay. And I just hope that, I find a good hospital or a good program. Because I know they can vary widely. I've heard from so many people.
Yeah.
But I'm glad, well, it's great to have this information to talk about it, talk about, trying to determine whether you need to be inpatient or if you could do outpatient or acute home care.
I mean, acute at-home care, that's a lot of self-managing. And I mean, that's just like anytime that you're self-employed or, you know, you're an artist and you also have to be your own promoter and your own manager. To be in distress and managing your own care, that's quite a huge feat. Way
I
to go
agree.
doing that.
I agree. I think I've only done it successfully since I got on lithium many years ago. And, my symptoms are not as severe. So I feel like it's a little easier to do the home care. But, I might not be on lithium forever. So we'll see. We'll see what happens.
We'll see. So
Yeah,
that's a tip for you all to go back and watch the lithium video also.
that's right. Our lithium video. I'll link it in the description box for you.
And you know what we didn't talk about is whether you're going to go to the hospital or because I said like, do you have an Excel spreadsheet? Do you have a psychiatric advance directive? I do.
No, I don't. We're going to do a video about them, and hopefully I will get one made. But I talked about them just a little bit in my last AMA. But yeah, Moss is the expert. So we're going to do a video about those. Well, don't worry, there's no pressure.
No, it's we're the expert. I am not an expert, not an expert, consultant expert.
But you know a lot about them. So I'm excited to
Well,
do that.
one involuntary inpatient stay will make it important to you.
Well, see, there you go. It sort of ties in with the topic for this video. We should wrap this up, but tell everyone where they can find you.
Oh, only places Instagram sporadically. My account might be public or private when you get there, but there's nomads dot roam and canaries, like the birds, dot roam. Or
Yes.
go to Jess's page and hunt through all the people that follow her, and you'll find me in that list.
Oh, God. Well, you definitely want to follow her. She has great content on Instagram, and she is a great friend of mine.
It's really good talking to you about everything.
Well, it was good having you. Thanks so much for being on the channel again, and we're gonna do more stuff. And thank you for watching this video, and I'll see you in the next one. Bye.